So, a mixture of reasons. There are some directly related to the disease, the underlying MS disease in the brain or the spinal cord, which then interferes with how nerves control the gut, because most of how our gut works is dependent on the nervous system. We don't consciously do very much apart from deciding to swallow or not and deciding to go to the bathroom or not. Everything that happens in between is by our nervous system working. When that nervous system gets damaged, as with MS, then that normal sort of traffic lights and traffic that moves through gets messed up, unfortunately. But beyond that, there's often other things that happen to MS patients or people with MS generally, like taking medications for other reasons, for their bladder or for mood, which have an effect on their bowel. There's things around mobility, which may mean that accessing the bathroom becomes harder so that a normal urge can't be met in time. And sometimes they have other diseases that occur, like IBS or things like something called celiac disease, which all of these things can occur in MS patients. And one of the important things is not to be too simplistic as doctors and nurses and assume that everything is MS related. Sometimes these other conditions are also contributors. It's a whole mixture of things related to the underlying nerve disease, the consequences of having MS and treatments, but then also parallel diseases. So the symptoms are by and large things which we would find a bit embarrassing to talk about. So the first thing to say is, as a professional, is to be comfortable talking about it, but as a patient to feel that what you're going to say is important to express in your own words and it's being heard by somebody who understands what's being said. So the commonest symptoms relate to constipation, i.e. difficulty with emptying your bowel, either in terms of how easy it is or how often it is, or other symptoms like having to help yourself or taking time or whatever. And then the other set of symptoms are related to bowel control, so not being able to stop yourself going when you need to go, or having to rush to the bathroom at short notice, or leaking material without being aware of it. So broadly speaking, problems with emptying and problems with control. But then there are some scenarios where patients with more advanced disease can also get complications where their bowel becomes dilated or bigger, and then that can interfere with how they swallow and how they eat and how things move through their gut as a whole. So the commonest things are constipation and incontinence, but then there are some rarer patients who will also get more complex set of problems which need specialist assessment. So the first thing is to turn to somebody and not to try and manage this on your own once you've tried that first step. So once you've tried adjusting your lifestyle, checking whether it's a dietary trigger, whether it is your mood, once you've done all that, once you've adjusted any simple laxatives you may have chosen to use, once you've adjusted the timing of the day you use your bowel, once you've done that, if you're still troubled, not to sit on it and say, well, that's my life, that's what to expect. It's to actually turn to somebody. And by and large, general practitioners will understandably not have the specialist knowledge around MS bowels in particular, but they will give you treatment based on your symptoms, and that will often be of some help. But the real sources of expertise often are the MS nurses, the MS team, and they increasingly are really familiar with bowel problems the way they have been with bladder and the way they obviously are with MS. So your MS nurse team is often a really invaluable source of information, and if they can't help, they'll have a network which can, or sometimes referral onwards from there. So I think if you ask me what I would do, I would tend to talk to my MS team as my first port of call, because they will often have some, and I would say probably 2/3 of the, maybe that's exaggerating, maybe half the time, patients can be given something straightforward without requiring complex onward referrals. So if you're afraid of thinking, oh God, I'm going to be opening up a hornet's nest of having a whole lot of tests done, that's very rarely needed. Most of it can be done simply. I think it's fair to say that most of what makes people better is using what we've got now, but in a sensible fashion, in a sensible order. But as you say, there are things always change happily. So sometimes there's treatments that we've used for other reasons, which we can bring into the MS patient group in a useful way. And sometimes there's treatments specifically around treating patients with nerve illnesses. So there are treatments broadly based around so-called irrigation, where we get patients to train themselves to wash their bowel out. And irrigation isn't just any longer just one system. There's now different variants of systems and different ways of combining oral medication with irrigation in terms of timing to do that better. So there's data around that, different irrigation systems and different ways of linking that with other treatments. There's certainly evolving therapies around nerve stimulation, mostly to treat bowel urgency, but increasingly there's groups which are working on how you can use bowel nerve stimulation in relatively invasive or non-invasive ways to improve bowel emptying. And then beyond all that, there are sort of innovative therapies, really sort of groundbreaking thinking around new agents to treat bowel contractions, or again, applying older agents for the bowel. So drugs people may have heard of, like ondansetron being used in the bowel, which are being studied specifically in this patient group to slow the bowel down. So there's a set of things. If people are looking at things like stem cells or transplants, at that moment, that stuff isn't working, and stuff around the microbiota, which people often had a real strong hope for a decade ago, thinking this is going to be a groundbreaking. Unfortunately, at the moment, that hasn't delivered any successes, but work ongoing there. But I think the more conventional lines of therapy are where we're going to get our first set of gains next. So this is absolutely nail on the head. For a lot of patients, they're not too bothered by how often they go. It's a thing about it happening at an inconvenient time when they're in the theatre, when they're on the way to work or whatever else. So for us, it's about trying to establish a routine. The biggest tip is to get into a routine. It doesn't have to be, you don't have to go to the loo every day. Okay, about 40% of healthy individuals go to the loo less than once a day, and they're completely normal. It's just getting into that routine so that you know when you do your bowel, it's dealt with, and you're not going to be caught short until the next time. So get into a routine, whatever that is, work with yourself and with your nurse team to try and get that organized. Second thing then is are these accidents happening because you haven't emptied fully? Is it actually not that you've got a problem with control, just you haven't emptied? In which case, again, with input from others, they'll say, look, actually, you probably need to empty a bit more so you don't empty at the wrong moment, which can seem a bit counterintuitive because people are thinking, oh, no, I don't want to go less. And it's actually about going in the right time to an adequate amount. So there's that part sometimes. And again, that needs somebody external to help you find that balance. And sometimes it is truly due to urgency, where the nerve supply to your bottom muscles isn't as good as it should be. And again, there are things we can do to help people train themselves to use their bottom better, or to train themselves to use medication so that they can help supplement that. So that's a bit of a vague answer covering lots of bases, but it does show the fact that actually unpredictability of bowel pattern is a common problem and has a number of causes, and giving a single tip isn't very possible other than getting into a routine. If that doesn't help, then you need to try and think about what specifically is causing your unpredictability. Yes, indeed. So it's true that caffeine, especially if you're a relatively naive user of caffeine, can be a stimulant to bowel contraction and can make your bottom muscles, so-called anal muscles, a bit looser. So that combination, if you're new to it, or relatively a rare user and then have a big dose of caffeine, can trigger people to go to the loo. But people who are habituated coffee users, 2 or 3 cups a day, your body tolerates that effect pretty well. And so the caffeine effect doesn't have much of a direct stimulant on your gut. There may be a psychological aspect of it, which is really important to recognize and embrace, which is that people say, look, I'd have a cigarette or have a coffee and then I need to go to the loo. That's how it's always been. That's grand. I mean, not the cigarette, obviously, but the coffee thing is actually, if that's your sort of the way your brain clicks into place to make you want to go, that's fine. So if it's part of your pattern and your routine, great. But I guess what I'm saying is that if you're relatively naive, you're somebody who has the occasional coffee every so often, you may then find if you have a tiramisu or something very coffee rich, you suddenly need to rush to the bathroom. Don't be surprised by that. But adjusting coffee doses to change in somebody who's a regular coffee drinker probably doesn't have much mileage to help symptoms, unfortunately. So I think it's fair to say that there's a sort of a psychological dependence that comes with lots of things, and caffeine is one of those. Not as strongly as nicotine or alcohol, some of the other things we use, um, but and it's certainly true that excessive amounts of anything will cause what they call supraphysiological, above normal dosing, where it then becomes really individual. So some people will tolerate 10 cups of coffee a day, fine, but some people can move into that, and then it becomes a habit-forming thing. So once you're beyond that normal range, you then run the risk of it's a bit of Russian roulette of whether you get trouble. So yeah, I think I would say that anything much more than sort of 4 cups of coffee a day of a standard coffee would be probably something which runs the risk of you becoming overly patterned on that, in not specifically bad for a bowel way, but may have effects on your bladder or your cognitive function. So the bladder effect is probably much more important with higher doses of caffeine than the bowel one.